At this stage, I would really like to introduce Rebecca Ferrier, who's an advanced clinical physiotherapist in the area of orthopaedics at the Prince Charles Hospital. She has a special interest in rehabilitation of people who have a fractured neck of femur, and has been integral in the development and implementation of the multidisciplinary fractured neck of femur service at Prince Charles. Rebecca has also coordinated a statewide project implementing physio-led post-orthopaedic surgery review clinics. Thanks, Rebecca.
Thanks to my team of supporters in the third row. We did pretty much take over the entire stage. So thanks to the organisers very much for having me, and I was a last minute addition, and I'm very grateful for a child-free night here at the Sunshine Coast last night, even though I am just from Brisbane. So today I'm going to talk to you about our physio-led hip fracture review clinic, which we've been running at Prince Charles now for a few years. Hip fractures can be devastating, and globally 1.3 million patients suffer them. And as clinicians, we're focusing really hard on getting the journey right for the patients in the acute and subacute phase, all whilst working with system pressures that are crumbling under the increasing numbers. At Prince Charles alone, 521 hip fracture patients came through the door last year, and this year we're set to exceed 600. And we haven't had any increase in resourcing. So we know we need to do things differently and think of different strategies in this burden of healthcare. Orthopaedic surgeons are required to fix the fractures, and traditionally they're required to review these patients in an outpatient setting after discharge to really ascertain the success of their handiwork. But if we know hip fracture numbers are going up, then theatre cases are going up and clinic throughput is going up, how are our surgeons going to be able to see us when we want our knee and hips replaced? Or how are they going to be able to see the more complex patients? Well, lucky, physio's perfectly positioned to help out in this space. We can provide a cost-effective alternate pathway for these review appointments, and across the world, physios have been substituting for surgeons in the arthroplasty space. Look, dating back to Scotland in the 90s, and published data out of Bristol in 2008 on over 1,000 patients demonstrated there were great advantages to this model of care from a patient satisfaction point of view, and it freed up 2 new appointments per week for the surgeon. Closer to home, but in Victoria, the great work by Paula Harding and her team rolled out physio-led arthroplasty review clinics to 10 sites in 2014-15 with some HWA funding, and she demonstrated that 44% cheaper it was to deliver the services by the physio, and it freed up wait times to surgeons by up to 90% in some sites from 40%. At Prince Charles Hospital, we've been running a collaborative physio and orthopaedic hip fracture review clinic since 2018. Essentially a substitution model of care where an advanced physio can substitute for the surgeon and perform their routine post-operative reviews for our home-dwelling hip fracture patients. The objective is to provide a safe and effective pathway for patients, and in doing this we can increase surgeon capacity to review new or more complex patients, and in some case increase surgical activity. Now look, our story began when I was selfishly capturing physical outcomes data for my own research back in 2016. And in order to do this, I wanted to bring the patients back to one clinic per week so that I could capture this outcomes data instead of coming to all different clinics throughout the week based on whoever they were booked in under. Now look, some of the highlights of our journey for our clinic were mapped here to the ERIC Discrete Implementation Strategy Framework. Thanks, Jack. So at that point in time, some of our outcomes were actually unexpected. We actually noticed that 30% of patients that were booked in to have, or supposedly booked to have an outpatient orthopaedic appointment, actually never had them. Now this may have been because a few of our patients went to different rehab hospitals, and the rehab hospital thought that the acute hospital was booking the appointment and vice versa. We also had a multitude of surgeons that were admitting patients based on the day in which they presented, and each of those surgeons thought that they were reviewing these patients, but lots of the appointments were actually being missed. This was powerful data when we were presenting it back. We also leveraged off the existing evidence that physios can substitute in the arthroplasty space. The advanced physio shadowed into orthopaedic surgery clinics. We actually were lucky, we had a passionate group of multidisciplinary team members and great support from allied health and orthopaedics. So when my actual functional data came out and showed that our patients really weren't doing very well from a function point of view and quality of life point of view, the concept of continuing our hip fracture clinic moving forward was a bit of a no-brainer as a collaboration from orthopaedics and physiotherapy. This is a schematic of how we run the clinic. Essentially, I doubled the clinic capacity, so I can see the patients myself and the registrar can see the patients, and we can cross over as required. While it's a post-surgical review or triage and I check wounds and x-rays with my orthopaedic hat on, I can obviously provide advice and reassurance and education for the patients that are in front of me. I'll progress mobility aids in clinic and certainly refer a significant amount on to high-level balance and physiotherapy mostly after discharge, because this is the part that we found that lots of our patients were coming back afraid to leave the house, but all of our community-based rehab services had finished. Look, I've learnt a lot from my orthopaedic colleagues, and I'd like to think that some of our registrars have also learnt a lot and are treating their patients a bit more holistically as well. Our reportable KPIs are simple yet effective. We include occasions of service by the physio, occasions of service by the registrar as a measure of efficiency, and data from just over 2 years showed the advanced physios reviewed 346 patients in clinic. We did a crude cost analysis performed by just using the occasions of service multiplied by 20 minutes, which is the review clinic time, and it just suggested a small cost benefit of $330 across the 2 and a bit years that we had the data for. But this didn't take into consideration the 5,347 hours of orthopaedic overtime incurred through that period compared to 0 for physio. 81% of our patients required what we call an informal discussion or a hallway chat where I can speak to the registrar, and only 15 patients out of the 346 required formal escalation, and this was largely due to non-union, pain, and those that required surgical revision. There's been no patient complaints, critical incidents or other unintended consequences, so we are safe, and the overall net surgical time released over the 2 and a bit years was 110 hours. Look, I think we'd value add to our patients as well in their recovery, and I'm really excited to look at My Hip, My Voice moving forward to try and capture some of this qualitative data and really evaluate our model of care in this, what the patients think. And Beer and colleagues did a really great systematic review in 2021 looking at what recovery actually means. And it really just, she states, and rightly so, it depends on who you are. A surgeon may consider recovery as from fracture achieved with fixation and or arthroplasty, while the physios consider recovery as return to pre-fracture function. But what do the patients think? Well, they're a little bit more closely aligned to the physio. They consider recovery as return to pre-fracture activities or normal, enabling independence. Feelings of vulnerability were observed irrespective of the time since hip fracture and only diminished when recovery of function and activities enabled participation in valuable activities. So I guess this is the X factor or value add element we're trying to get within our clinic. Having routine checks of not only the surgical wound and the X-ray, but also allowing patients to identify their own feelings of recovery and or vulnerability. These conversations personally can be the most rewarding, as we often have time to hear the patient, their fears and concerns, and their perceived lack of progress, or the simple things like, can I get rid of my over-the-toilet frame, or can I get it back to dancing? Hopefully, published really soon is our short report in BMJ, and it's the Special Fragility Fracture Edition, and it just really highlights the implementation of our model of care, and to our knowledge it's the first of its kind in the world. And I'll just finish with Steve and one of our fearless leaders here. Apologies, Catherine, that's just the pause. But 3 years ago, I actually presented in South Australia to some physiotherapy colleagues, and we got a little snippet of what the doctors thought, and that was really at the start of our journey. And Steve here, he was a PHO, one of my original PHOs, and now he's back as a final term trainee, and he said, Beck, I've gone all around the state telling people to sit to stand, and I watch them get out of the chair and I look at them taking a few steps without their aid, so I do more than what I used to do with my hip fracture patients. Okay.
So I think it's an interesting clinic that allows the physios to give a perspective to the doctors who are seeing a patient that normally has a therapy-based limitation to returning to their previous function. it provides me with an opportunity to get that feedback in a real-time situation where previously I would have said, oh, we'll have to talk to physiotherapy. But I can get that. And those small milestones that we might be able to see and give immediate feedback to both the patient and their family end up being huge changes in what they experience in their initial treatment and their follow-up in what really is a stressful peri-morbid event.
Thanks.
We found the physio-led hip fracture clinic really beneficial. I think one of the key things is that the physiotherapists look often at slightly different things than we do. They're really focused on the mobility and the function. They had the time to really try and get to the bottom of the problems, and we've had the benefits then of providing help to many, many patients.
Thank you. And that's really all for me.